I will like to invite Dr. PC Kathuria sir. Topic is Allergen Immunotherapy in the practice of the allergic asthma. And Dr. PC Kathuria is a senior consultant, Department of Allergy and Asthma, BL Kapoor Hospital, New Delhi. His 43-year experience in the clinical practice, allergy and asthma, and he is a renowned allergy consultant in the BL Kapoor Hospital, Delhi. Now, Dr. PC Kathuria.
Good evening, everybody. My greetings to all. Friends, ladies and gentlemen, Chairperson, regards to all the senior fellows and also regards to Dr. Ansari, who I met after many years. My topic is on allergen immunotherapy in allergic asthma, where we are now. My statement starts with anyone can do skin test, but very few knows how to interpret the skin test sensitization with the history. And the most difficult part in clinical practice of allergy is how to select the allergen for allergen-specific immunotherapy. Everything is evolving in this universe, so is the medicine, so is the allergen immunotherapy. Started way back in 1910, the subcutaneous immunotherapy, and 1986, started the sublingual immunotherapy, from evidence-based medicines to the reality-based medicine. 100 years back, it was the skin test only, for which afterwards we used to AIT, allergen immunotherapy. But now in this world of the molecular allergology, we have got a specific purified standardized allergen extracts along with the skin test also. Initially, most of the patients, they were monosensitized, but now at present we see a lot of the patients of a polysensitized associated with the allergic rhinitis, rhinoconjunctivitis, rhinosinusitis, or food allergy, atopic dermatitis along with these patients. All over the world, subcutaneous is the first which is being used except in certain European countries. In India also, we use the subcutaneous allergen immunotherapy rather than the sublingual, as the DCI still has not approved in it. If you look at the comparison between these, subcutaneous has a better edge over the sublingual immunotherapy, not only because that it has got a long-lasting effect, but sublingual immunotherapy has certain limitations. Meta-analysis done, subcutaneous immunotherapy is much better than the sublingual immunotherapy. No questions of the efficacy and safety in case of the respiratory allergy and venom allergy, but there are certain question mark in the other, right, food allergy or latex allergy. You see, the guidelines has also accepted there is a high efficacy in case of the respiratory allergy as well as but there is a modest efficacy in case of the atopic dermatitis or OAS. Why there is a need of allergen immunotherapy? Because if you look at the 60 to 80% of the patient of asthmatic, they are atopic, allergic, IG mediated, and more than 50% in adult also they are atopic. So these patients, if you look at the causative effect, is the allergens. In every allergen exposure, there is a loss of the lung function. That's why most of these patients, the severity of the disease occurs. So if you treat with these etiological factors, if you detect this, at least you can give the remissions to in due course of the time or disease control. What we get is not only the disease control, disease modification, as well as the disease remission, but also we can prevent the ongoing inflammation, ongoing remodeling in these cases. We have got a 5 parameters which we see that it should be done with this, like the exacerbations, lung functions, ICS withdrawal, symptom scoring and quality of the life, which we look for once we start with the AIT. Now if you look at what is new in this, If you have caught a case of the seasonal allergic rhinitis, seasonal bronchial asthma, either you use subcutaneous immunotherapy or sublingual immunotherapy, there is a hard data, the evidence is A. But if a patient belongs to the perennial allergic bronchial asthma, perennial allergic rhinitis, then the evidence is poor. You have to only go for the subcutaneous immunotherapy. And now the sublingual immunotherapy, which the GINA guidelines or the YAKI guidelines, other guidelines, it is an add-on therapy to control the symptoms, to control the exacerbations, and to increase the quality of the life. But if you have got these studies, which is the RED, the reality-based studies, then it has found that there is a decrease in the bronchial hyperresponsiveness as well as there is a long-lasting effect, which differs from the rest of the drugs. None of the drugs which is do like this. So there is a complex journey of this allergen immunotherapy. If you look at this, 110 years back, this Dr. Noon published first paper. This is a protocol which is given here, that if you start with this up dosing as well as then the maintenance dosing, then there is a response is there, but the most of our centers, they are using this protocol. But most of these patients all over the world, hardly 20 to 25% they are on allergen immunotherapy. Reason is behind that there is adverse effects during this journey. There is a poor adherence during this journey. Then now after the 2011, with the advent of the biological, has really paradigm shift towards from conventional immunotherapy to the cluster immunotherapy. So we use at present not only the allergen immunotherapy, but also the biological also. The fundamental difference between these two, that biological they act, but the response lost once you stop it. But the allergen immunotherapy, they have got a long lasting effect, and there is a reduction in the bronchial hyperresponsiveness. So not only it increases the effectiveness, not only it decreases the adverse events, but at the same time there is a extend the allergen immunotherapy even in a partially controlled asthma and has got a steroid sparing effect. So if you use the allergen immunotherapy in a pre-modeling stage, the definition of pre-modeling is there. If the duration is very less than the age of the 10 years, or if there is a patients, those who are a normal lung functions, or children's, then there is a remission in these cases. But if you use the allergen immunotherapy in a state of the chronic inflammation or already the remodeling has started, then the results are only the response is the control of the disease. Remission is not possible. So right patients, right test and the right interpretation is good. If you look at the comorbidities, most of our patients, they are associated with the allergic rhinitis, food allergy, atopic dermatitis. Now these patients, they need special treatment. Why? Because most of these patients, they are polysensitized, and the selection is very important. These 7 groups of the allergens, if you know it, these allergens you have to judicially select which patients is there. We treat our patients with the major allergens, not the cross-reacting allergens or the other allergens which has got the incompatibility. So question is there, where we can prevent our allergic asthma? Can we prevent in our children so that it should not go into the ongoing inflammations or chronic remodeling? So we have divided into 3 phases. Can we prevent to primary prevention, where the child is risky, skin test is positive, but there is a patient is asymptomatic, or secondary prevention, where the patient is symptomatic, but the disease is very mild, only the rhinitis with or without intermittent asthma. And third is the tertiary prevention that we will look at, but all over the world, it is the secondary prevention. Lot of the voluminous material is there which can reduce the ongoing inflammation if you select your patients in a secondary prevention. But in tertiary prevention, once there is a chronic remodeling, very difficult, only the intensity and the severity can be decreased. But in primary prevention, very little role. Now look at this. What are the primary prevention? Child at a risk phase. Are those children, those who are asymptomatic? in these patients, is there evidence? 3 studies has been done. It was found that if you give even the sublingual immunotherapy, efficacy is poor. Go already these patients, they doesn't have even the inflammation, only the sensitization. So these patients still we need more study for evidence. Second is the cases of the seasonal allergic rhinitis or seasonal allergic asthma. These are the voluminous of the patients which you can select and do the allergen immunotherapy. Most of these evidence is available. There is a gap study, there is a PAT study which has already done. These are the robust study done, and it has confirmed that if you select these patients, at least you can reduce the ongoing inflammation, you can reduce the ongoing remodeling. PAT study has been done for 3 years and 7 years follow-up done, and they found that there is a reduction in the bronchial hyperreactivity, and most of these patients, those who took hardly 25%, they get asthma, 70% there is a reduction in there. Another study 2023 has come, it has already confirmed if patient is a pollen immunotherapy, there is a remission. But if there is a patient of the perennial allergen, at least you can decrease the bronchial hyperreactivity. Now, if 20 years follow-up has been done, that allergen immunotherapy decreases the new sensitization. So, 14-year studies also has been done. Long back, if you look at many studies, has confirmed that allergen immunotherapy has got the decrease in the intensity and severity as well as preventing the ongoing inflammation. So, ladies and gentlemen, my take-home message is there that if you have got a monosensitized patient, if your children are there and 3-year give, at least you can give remissions to these patients, but you have to test early, treat early and train the immunity in these patients. Now we are coming to the asthmatic patients. What will you do in an asthmatic patients if the patient is a perennial? Perennial means the patient does not have even the 10 to 15 days in a year in which without LABA and ICS. These patients need now how to differentiate phenotypic and endotypic differentiation. So select these patients. Now the GINA guidelines has come 2017, but before that we have got a lot of the evidence is there that these patients they need in step 2, step 3 and step 4 allergen immunotherapy. GINA has given the evidence that if you give tablets only, not the drops of the sublingual immunotherapy. GINA has only looked at the control only, exacerbations, not for the bronchial hyperreactivity. And this is based on the studies. They found that these patients, they were prevented from ongoing from step 1 to step 2 or step 2 to step 3. Or these patients strongly suggest that not only prevent the occurrence of asthma also. 2023 we have found that there is no questions of efficacy in a house dust mite and a grass pollen allergen immunotherapy. But these patients, they need purely selections of the allergens. Now coming to the another guidelines, if you have a patient who is atopic, allergic, IG mediated, you select. Rather than using the high dose of the ICS LAVA, ICS you make it a medium or the high dose, keep the allergen immunotherapy at the top of there. And if you have got a special case, those who are a house dust mite, these patients should be given even in a partially controlled asthma. But the condition is there that these patients must have a FE1 more than 70% and there should not be any exacerbation for the last 12 months. Why house dust mite is important? If you look at this, 650 million cases of the allergic rhinitis all over the world, 350 million cases of the asthma, 50% of these patients, they are sensitive to only single allergen, and these patients, they need allergen immunotherapy. I will not go into any further studies because of the time constraints, but just to take home message is there that in those cases, those are tertiary prevention, those who are already well associated with the comorbidities, these patients, they need biological. We need now at present the standard purified product formulations, not the crude extracts which were using for the last many years. And if you use a biological on this, at least you can give the early response, better response, and these patients, they respond early. Now look at the study, recently it has come 2023, subcutaneous immunotherapy with the biological has a much better response. So ladies and gentlemen, these are the cases which we have published, that biological and allergen immunotherapy is the talk of the today, not the allergen immunotherapy itself. It is safe and effective and give more rapid relief, and even the build-up dose has been decreased up to the 6 weeks, which was 7.5 months before. So biological is given. A lot of the studies are going on. Already omalizumab for the last 20 years we have with the omalizumab with us. Now the study on the anti-IL-4 alpha unit is being done, and the study also is going on the TSLP. Let us see, the outlook is better and the future is bright if you select the judicious selection of the allergen. With this, thank you very much for your kind attention. Okay, cut.
Thank you very much, sir. I would request Dr. A.K. Singh, sir, to present Memento and Angavastram to Dr. P.C. Kathuria, sir. Dr. J.K. Mishra, sir. Sir, Memento and Angavastram.